shock index in trauma is the three indices which you need to know: shock index, modified shock index, and rope over pressure evaluation. Shock index is heart rate to systolic blood pressure. Modified is heart rate to mean arterial pressure. So shock index is heart rate to systolic blood pressure, and above 0.9 is associated with high mortality. Modified shock index is heart rate over mean arterial pressure. More than 1.3 again is hypodynamic state, excessive blood loss. Modified arterial pressure, mean arterial pressure, modified shock index. And rope, rate over pressure evaluation. Here you take heart rate over systolic blood pressure minus diastolic blood pressure. The difference in systolic and diastolic pressure evaluation. This should be less than, rope value of less than 3 is stable, but when the heart rate will rise and systolic will fall, the value will go down. So more than 3 is kind of hemorrhagic shock and relatively poor prognosis. So these three indices, shock index, modified, they have already asked one shock index in all India. So heart rate upon systolic blood pressure is shock index. Modified shock index is heart rate upon mean arterial pressure. And the shock index more than 0.9 is considered high mortality. Modified more than 1.3. And rope, which is rope over pressure evaluation, more than 3 is relatively poor prognosis. A 60-year-old female presented with off and on bleeding per rectum and anemia. So she gives history of recurrent epistaxis since childhood. Telangiectasia was found on mucosa and nail bed. So you can see telangiectasia at the nail bed, in the mucosa, in the GIT, and she is bleeding. Out of these, what is the most probable diagnosis? Colonoscopy revealed AV malformation and telangiectasia. Here, most probable diagnosis is Osler-Weber-Rendu syndrome. And you see, this is autosomal dominant, chromosome 9, or activin receptor-like kinase type 1, ALK1 in chromosome 12, endocrine gene on chromosome 9 or ALK1. And Curacao criteria is used for the diagnosis, which is simple: epistaxis, telangiectasia, and AV malformation in any of these states, and family history. So out of these 3, if out of these 4, 3 is positive, then it's confirmed Osler-Weber-Rendu syndrome, which presents with epistaxis and bleeding, GI bleeding. Autosomal dominant, so always family member should be screened. 50% risk of family member having this problem. A 60-year-old lady with metastatic breast cancer was treated by radiotherapy, 300 rats or 30 gray, 3,000 rats or 30 gray to left hip area. Radiotherapy course was uneventful. After 2 weeks of radiotherapy, doxorubicin chemo was started. After 20 days, she developed localized painful erythematous maculopeplar eruption over the left hip area. What this phenomena is known as? This is called radiation recall dermatitis. You see, in this condition, during radiotherapy, there is no problem. But subsequently, when patient received, this was first of all reported with the use of actinomycin D. So in some question, they may give you some chemotherapy name and ask which can cause. There are 15 chemotherapy that can cause this, so many. So it's not, but first of all, it was noticed in actinomycin D. Later on, patient develops at the site of radiation when chemo is given, these kind of red, erythematous, itchy, painful maculopeplar eruptions. So radiation recall is a reaction to skin site of previous eradication, while at the time of radiation there was no problem, not evident at the time of radiation. First case was reported by actinomycin D, but many 5-FU, hydroxyurea, vinblastine, methotrexate, adriamycin. Adriamycin and doxorubicin are same. Adriamycin and doxorubicin are same, and they cause dilated cardiomyopathy. Etoposide, tamoxifen, bleomycin, melphalan is very commonly used for melanoma. Paclitaxel, a microtubule stabilizer. Docetaxel, gemcitabine was a drug for pancreas. Now we use folfirinox. Pegylated liposomal deoxyribicin. I mean, so many drugs can cause this. Use of topical steroid and just withdraw the agent. This is the treatment for this condition. Okay. So this is radiation recall dermatitis, where at the site of radiation, when subsequent chemotherapy is given, patient develop these kind of rashes. Apple peel sign is seen in which type of bowel atresia? Apple peel sign is, you see, type 1 atresia means the bowel is normal, there's no problem from outside, but inside you have a membrane kind of thing, inside only. Type 2, there's a gap in the bowel wall. From outside you can see, but mesentery is intact, it's going up to the edge. Type 3, gap in the wall and gap in the mesentery. And type 4, multiple. I will draw the one again, it's not very good. So type 1 is just no gap in wall, no gap in mesentery, inside your membrane kind of thing. So type 1 is caused by improper canalization where you have membrane, while 2, 3, 4 are caused by ischemia of the bowel in fetus. So type 1 there's a gap in the wall only, type 2 gap in the wall and gap in the mesentery, and type 3 gap in the wall, gap in mesentery, this is type 4. Now type 3 is A and B. So this is the, okay, what happened here? Why it is going to the next page? Okay, so type 1 from outside this normal only membrane, type 2 there's a gap in the wall, type 3 gap in wall, gap in mesentery. 3B, the length of the mesentery is shorter than the length of bowel. So it gets kind of crumpled or something like this, giving apple peel appearance. So type 3 is basically gap in the wall, gap in the mesentery, but mesentery length is shorter, so you do get apple peel appearance. So apple peel appearance is a feature of type 3B. It's all India question already, type 3B. Which of the following is not a contraindication of endovenous laser ablation for varicose vein? Endovenous laser ablation called ELVA, ELVA, endo laser venous ablation, is contraindicated in pregnant or breastfeeding female? Yes. Obstructed. When there's a deep vein obstruction, only superficial means patent, you cannot afford to block both. So it's a contraindication. International normalized ratio less than 1.2 is ideal, but 2 is not a contraindication. This is not a contraindication you can give. And severe hypercoagulable syndrome, yes, this also you should not do. So pregnant and breastfeeding, obstructed deep liver dysfunction, allergy to any amide or ester by LA cannot be given, uncontrolled coagulopathy, but between 2 and 3 it is okay. You can go for this. Hypercoagulable state, sciatic vein reflux, and thrombus or synechiae. The veins are very tortuous and having multiple blocks. Now probably you cannot do this. So these are the contraindication of endovenous laser ablation. Surgical Apgar score includes all except. Surgical Apgar score is a very good score to, it includes 3 things: blood loss, mean arterial pressure, and heart rate. Blood, and you give 0, 1, 2, 3, 4 number. Higher the score, better is the prognosis. So like less than 300 blood loss, 300 to 600, 600 to liter, more than 1 liter, like this. Mean arterial pressure, heart rate, 85 to 4 is only 1, 2, 3, 4. 4 is only heart rate. Rest only 1 to 0, 1 to 0, 1, 2, 3. 4 is only heart rate. So more than 85, 75 to 85, 65 to 75, 55 less than 55. So mean arterial pressure like this. So lower the score, poorer is the prognosis. So if the score is more, only 3 things you take, and rest are 0 to 3 while heart rate is 0 to 4. So if the score is more than 7, usual, less than 6 needs observation, less than 4 needs ICU care. So these 3 parameters, right, something like this, but we need not remember the score. Remember, Apgar score, surgical Apgar score includes blood loss, mean arterial pressure, heart rate, not respiratory rate. And if the score is more than 7, it's fine. Less than 4, ICU care. Okay. Ideal treatment for T3N1 bladder cancer. Urinary bladder cancer has been divided into superficial and deep. Superficial means TA, TIS, T1. TA is polyp, pedunculated polyp, TIS carcinoma T2, T1 is submucosa. Here you don't have to go for radical surgery. Only transurethral resection of bladder tumor will suffice. Additionally, for carcinoma in situ, intravesical BCG and T1 intravesical chemotherapy can be given. So if TA is low grade, only polypectomy is okay. TA high grade, then you need regular follow-up and chemotherapy. So TURBT is the treatment. Here you can give intravesical BCG. Here you can give intravesical. This chemotherapy is not intravenous, intravesical. Most commonly used is mitomycin C. Adriamycin thiazide is also approved, but mitomycin C intravesical is most commonly used. Mito C. But for any tumor that has gone into muscle or node, the treatment is radical cystectomy. Either muscle is invaded or node positive, and then you do, after radical cystectomy, you do ileal conduit. This is the most common urinary diversion technique, ileal conduit, which causes hyperchloremic, hypokalemic acidosis. These are the MCQs you have. What is the most common electrolyte imbalance? Of ileal conduit, hyperchloremic, hypokalemic acidosis. Which is the most common diversion technique? Ileal conduit. So any cancer T2 or N1, you have to go for radical cystectomy. Like here, this is T2, T3, N1, so obviously radical cystectomy followed by chemotherapy. Okay. Main chemotherapy is cisplatin, but it's given along with vincristine, methotrexate, even adriamycin. Which of the following is not essentially removed in radical nephrectomy for upper pole RCC? This is little controversial, but more or less correct. Like radical nephrectomy, you can do less than 4 centimeter, which is T1A, we can do partial nephrectomy. But even up to 7 centimeter, that is T1B, now partial nephrectomy is recommended. You can go up to 7 centimeter. But in radical nephrectomy like T2 onwards, you remove, first of all, the best approach is transperitoneal. Through the abdomen. You can go from the flank, but transperitoneal is better. Number 2, first you ligate artery, renal artery, then vein, and then go for ureter. What all you remove? This is the kidney, this is the ureter, this is the aorta, bifurcation, external, internal iliac. Ureter will cross exactly at the bifurcation of internal and external iliac here. So this is the adrenal, this is the girotas fascia. So kidney is removed along with intact girotas fascia. So complete perinephric fat is removed. Adrenal is optional, but because it's an upper pole RCC, that's why we are removing adrenal. For lower pole, we don't remove adrenal anymore now. And till bifurcation of common iliac, we remove ureter. This is the complete abdominal ureter. Abdominal ureter is till bifurcation of common iliac. Pelvic ureter is below that. So complete pelvic brim, above pelvic brim. So complete abdominal ureter needs to be removed. So adrenal, yes. In this case, I'll remove because upper pole RCC. Ureter till, yes. Love and Bailey says ureter should be removed as long as possible. Some books say till bifurcation of aorta. Right answer is till bifurcation of common iliac. That's the abdominal ureter. And perinephric fat. Retroperitoneal node again are optional. This is not mandatory. Even this is optional. But in this case, it's upper pole RCC, so it should be removed. But nodes are not a mandatory step in renal cell cancer surgery. A 10-year-old boy presented with a cystic midline swelling. The swelling was moving up with protrusion of tongue and swallowing. Which of the following is wrong statement about this condition? So if it's moving up with swallowing as well as protrusion of tongue, this is a thyroglossal cyst, which is a remnant of thyroglossal duct. So when the thyroid comes down, this is the tongue. This is the foramen of cecum. And from here, thyroid comes down through this tract. This is the thyroid. This cyst will disappear. But generally, if it persists, then the upper part will persist and we have a cyst with tract attached to tongue. A tract attached to pheromone cecum, base of tongue. That's why it moves up with protrusion of tongue. Most common position is subhyoid, that's correct. Cyst trunk operation is done, that's correct, because the whole cyst, the whole tract with central hyoid body should be removed. That's also correct. Otherwise recurrence will be there. Fistula and cyst, treatment is cyst trunk operation. Complete cyst, complete tract and body of hyoid. Thyroid scan, yes, this should always be done, because in some cases, roughly 10% cases, the whole thyroid will be inside the cyst only. So if you do not do that scan and see the exact location of thyroid, you excise the cyst, accidentally you may even remove thyroid also. So sometimes inside the cyst you do get thyroid tissues. To rule out that, scan should be done. Follicular cancer you don't get in cyst, you get papillary cancer. So in about 1 to 3% cases, papillary cancer may be found, not follicular. So wrong answer is B, of course. Ex utero intrapartum treatment can be required in which of the following conditions? This procedure is done when you suspect respiratory obstruction immediately after birth. Anything in the neck pressing the respiratory tract. Before birth in uterus, patient, the child, the fetus is taking nutrition, oxygen from the placenta, not from outside. He is not breathing. So no problem. But when he has to breathe and there is a respiratory compromise by a big lump in the neck, then you need this technique. So teratomas, chaos and cystic hygroma. These are the indication of ex utero intrapartum treatment. You see what we do here. You deliver the baby like you are doing cesarean. Don't ligate and cut the placenta. Let the oxygen come through this. First, ensure the patency of airway. Maybe by intubation, whatever, patency. Then you cut the placenta. So this is called ex utero, outside the uterus, intrapartum, during delivery. You are doing this. So airway compression, either teratomas or cystic hygromas or congenital high airway obstruction called chaos. So in these conditions, any condition causing obstruction where child, like this kind of cystic hygroma, this kind here, very big, they can cause obstruction to the respiratory tract. And cystic hygroma basically is obliterated lymphatic. Most common site is neck posterior triangle, may be found in other part of neck, axilla and groin as well. And treatment is surgical excision, but you do have certain restoring agent and OK432 and all those. So, but exit is needed in cystic hygroma. ERCP is indicated in acute pancreatitis in. You see, this is liver. This is the right hepatic, left hepatic, common hepatic gallbladder. And the reason for pancreatitis gallstone is that a stone or a sludge or concretion comes here, blocks the common duct between the CBD and pancreatic duct. Now the content of the bile juice, they go into the pancreatic duct. Phospholipase activates the enzyme and pancreatitis process starts. OP common channel theory, OPIE, OP common channel theory, which says both ducts are commonly, attached and then. So in this case, if we do ERCP and simply do papillotomy or sphincterotomy or remove the obstruction, patient will start recovering. Provided we do ERCP within 48 hours. That's the golden period. Maximum time is 72 hours. After 72 hours, the inflammatory cascade starts and SIRS sets in. Now it is not helpful. So gallstone pancreatitis ERCP can be done within 48 hours. This is the only indication of ERCP. Sometimes we do ERCP for complications like pseudocyst and know the communication of cyst and pancreas or stenting of. But in acute phase of pancreatitis, only one indication. This is gallstone pancreatitis within 48 hours. This is the golden period. 2.5 centimeter appendiceal carcinoid with liver metastasis is best treated by. You see, carcinoid, the treatment is surgery. The octreotide we give for symptomatic relief only. Octreotide or lanreotide. Streptozotocin with 5-FU or adriamycin is as a chemotherapy, but main treatment is surgery. Any carcinoid which is more than 1 centimeter has a high risk of cancer. Any carcinoid which is more than 2 centimeter is cancer, should be treated like a cancer. And then you do radical surgery. Carcinoid is one cancer where liver secondaries are operable. If we have liver secondaries from gallbladder, pancreas, stomach, they are inoperable. But colorectal cancer, adenocarcinoma, pancreatic neuroendocrine tumor, carcinoid, liver secondaries are operable. So what we do here in these cases, liver secondaries are operable. So for appendix, the protocol of carcinoid is, if it is less than 1 centimeter, then less than 1 centimeter, then we do appendicectomy. More than 2 centimeter, then we do right hemicolectomy. But when the carcinoid is in between 1 and 2 centimeter, then you see the site. If it is at the base of appendix more towards cecum, like this is the mesoappendix, the pink area. So if it is at the base within 2 centimeter of cecum or in the here towards the mesentery side, then we do right hemicolectomy. If it is at the tip or antimesenteric border, then we do appendicectomy. So carcinoid of the appendix less than 1 centimeter benign appendicectomy, more than 2 centimeter right hemicolectomy. While between 1 and 2 centimeter towards the tip or antimesenteric border, go for appendicectomy. Towards the base of mesenteric border, go for right hemicolectomy. And liver secondaries can be operated and removed. Then you can give chemotherapy, of course. So the best answer here is not appendicectomy, rather right hemicolectomy, because it's more than 2.5, and liver secondaries can also be removed with chemotherapy. So appendicectomy is not done. No, it's malignant. And palliative? No, at this moment it's still operable. One new treatment for carcinoid is LU177 dotatate. LU177 dotatate. Dotatate it's a somatostatin analog, DOTATAT. So this will get attached to somatostatin receptor of the carcinoid. So this is basically to take the lutetium to the receptor, and lutetium, LU is lutetium or lutetium 177, which has a high beta emission. This lutetium is approved for GIT carcinoid and for SRS positive somatostatin receptor positive carcinoid. Only SRS negative, the dotatate will not go there, so you cannot give. So answer right is A. Finally, the last question. Which of the following is false statement about silk suture? It loses the strength 20% if made wet. It's braided and coated. Loses 80 to 100% strength in 6 months. It's kept in isopropyl alcohol in suture pack. Only one suture is kept in fluid in pack. When you open, some fluid will come out with the suture. No other suture needs fluid, and that is chromic catgut. So silk, which is natural, non-absorbable, Though it is non-absorbable does not mean it provides strength lifelong. It will lose its strength in 6 months time. And it is braided, so it has a higher risk of infection because it's braided. So those grooves, the bacteria grows there. So it's not considered a good suture in infected area, but otherwise it's quite a good suture. For vessel ligation for skin still we use this. So this, the wrong statement is D. Only chromic catgut is kept in a solution, not silk. Silk is kept dry. So that's, and now this is high time for you to put in a best effort. Don't be little lax and complacent now. So all the best to all of you. Thank you.